Hello, this is Professor Wheeler here again to guide you through another set of psychiatric disorders. Today we have somatic symptom disorder and related disorders. The reading for this lecture is our open educational resource, Mental Health is a Verb, the chapter I have put in your module in Canvas. Our objectives: number one, discuss historical aspects and epidemiological statistics related to somatic symptom disorder and related disorders. Number two, describe somatic symptom disorder, also known as SSD, illness anxiety disorder, formerly known as hypochondriasis, functional neurological symptom disorder, formerly known as conversion disorder, and factitious disorder, formerly known as Munchausen syndrome. Number three, identifying predisposing factors in the development of somatic symptom disorder and related disorders. Objective 4, describe appropriate nursing interventions for behaviors associated with SSD and related disorders. Number 5, what is factitious disorder by proxy? Number 6, how is factitious disorder similar to malingering and how is it different? Number 7, define label indifference and how it can help identify if the patient has functional neurological symptom disorder, conversion disorder, instead of a serious physical condition. So these objectives, these slides are also, the content is at the end of this presentation, and I will go over those in detail at that point. Somatic symptom and related disorders are characterized by physical symptoms suggesting a medical disease, but without demonstratable organic pathology or a known pathophysiological mechanism to account for them. Remember, the word somatic means related to the body. Historical aspects. Somatic symptom disorder and related disorders have thought to occur in response to repressed severe anxiety. A quick look at the epidemiological statistics. So the prevalence is estimated to be 5 to 7% of the general population, with higher female representation in a ratio of 10 females to 1 male. The prevalence increases to approximately 17% of the primary care patient population, which makes sense. If you have, if you have a disorder like this, you're going to seek medical treatment. The prevalence is likely in certain patient populations with functional disorders such as fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, and also certain personality disorders, particularly avoidant, paranoid, and obsessive compulsive. All right, so let's look at the somatic symptom disorder diagnostic criteria. So there's 3 different sections here. The first one, they have one or more somatic symptoms that are distressing or result in significant disruption of daily life. And so they have headaches, or they have backaches, or some kind of pain like that. Or could be chest pain, shortness of breath. That's a common one. All right, number B, excessive thoughts, feelings, and behaviors related to the somatic symptoms or associated health concerns are manifested by at least one of the following. So disproportionate and persistent thoughts about the seriousness of one's symptoms. So in other words, a little shortness of breath, the person believes they're going to die. They could also have persistently high level of anxiety about health or symptoms. Or the third possibility is excessive time and energy devoted to these symptoms or health concerns. So they just need one of those, the following, the previous 3 I just mentioned. And then C, any one somatic symptom may not be continuously present, and so it doesn't have to be the same symptom, but there's always a symptom for at least 6 months. So common complications, drug abuse and dependence are common complications of somatic symptom disorder. You can you can imagine a doctor sees this patient coming in over and over again with complaints of pain. Eventually the doctor might give in and, prescribe them some kind of narcotic, and then the patient with all of their health concerns are going to take that, and then we have possibility that they're going to get an addiction. So the personality characteristics, they're very emotional, they're dependent. In other words, they tend to see other people kind of in charge of their own well-being, and they're very preoccupied with symptoms and oneself. And what that means is they're very focused on their own, themselves. They're not really connected to the world outside themselves very well. And then initially focus, oh, this is how to help them. What we want to do is initially focus on their physical symptoms to build rapport. What these patients tend to hear a lot when they can't, there isn't any basis of their physical symptoms that they're having, is it's all in your head. And if you've ever been in that situation where somebody tells you your pain, it's all in your head, that makes you want to disconnect from that person, because what you're experiencing. It's very invalidating for somebody to tell you it's all in your head. So we want to stay away from that kind of thing. What we want to do to build rapport with that patient is initially focus on their physical symptoms so they feel, you're taking them seriously, and then gradually attempt to ask them, what are the stressors in your life? Have you had any losses recently? And get an idea of their psychological concerns, and then try to focus, because their physical symptoms, if they have this condition, they're going to get better once they feel better psychologically. So initially focus on their physical symptoms they're presenting with, and then gradually move them into talking about their psychological concerns. Okay, so our first related disorder to somatic symptom disorder is illness anxiety disorder, formerly known as hypochondriasis. You probably remember from my earlier lectures that the American Psychiatric Association, when a diagnostic term is well known in the culture outside of the fields of psychiatry and psychology, then they try to change the name. Hypochondriasis, it became famous with certain comedians that would talk about their hypochondriasis and make it funny. Um, Woody Allen comes to mind, Richard Lewis, those type of people. Um, and so the American Psychiatric Association, they don't want, when they give a patient a diagnosis, for them to think of what Richard Jenny or Richard Lewis or one of those comedians had to say about it. And so they changed the name, and they try to make it more descriptive also. So illness anxiety disorder continued. The defining feature of this condition is that they don't have a symptom that they're imagining. They misinterpret their own body's normal feelings as pathological. So any little twinge, any little minor ache, they they've really focused in on that. And when you focus in on something, you make it larger. You make it more likely to increase. And so they don't have symptoms that are coming on that are major, but they're all minor things that they're feeling that they think is going to be a big deal. An example, a little soreness in your calf. Most people, if maybe you went on a hike the day before, or you did some kind of strenuous activity that you don't usually do, you might have a little soreness in your calf, in your lower leg. And so the person with illness anxiety disorder would feel that little tightness and think, oh my God, I've got a blood clot. It's going to break off and go to my brain and kill me. And so that's a good example of the kind of exaggerated sensations that they have just in response to normal body discomforts. So you can imagine with this disorder, anxiety and depression are common. So our next related disorder is called functional neurological symptom disorder. This formerly was known as conversion disorder. You see the graphic of the patient in the wheelchair, and that's because one of the very common ones is that suddenly the person can't walk. Um, so yeah, there's a change in the bodily functions. The the classic conversion symptoms, it's usually a neurological thing, but the common ones I have here in the next one, presenting symptom, there's a symptom there where there's a loss of function. So that's what's different about this one versus illness anxiety doesn't have a symptom like this, and either does somatic somatic symptom disorder. This is a loss of function, and generally the loss of whatever function it is protects them from whatever they're anxious about. I may have given you the example at the start of this class where I talked about a student that, in the context of telling you why we have to have a 5% penalty when you can't make it to an exam because you're ill. It sounds kind of mean that you're sick and then we punish you for that. But if we didn't, you might have this condition where you actually develop a somatic problem. It's not usually this extreme, but I probably gave you the example of the student one time during a an exam. She suddenly became blind and couldn't see, and so that protected her from having to take the exam. She wasn't able to take the exam, and so she did have the 5% penalty. She did end up failing the class, but don't feel too bad for her. She came back the next year and passed. Um, But anyway, that's kind of a classic thing. The symptom usually protects them for whatever they're anxious about. If they're anxious about, I think there's a classic case where a firefighter suddenly couldn't walk after they were traumatized when during a dangerous fire that they were involved in. Um, so the symptom protects you from what you're nervous about. And the telling thing that you can tell if is something we call la belle indifference. It's a French word, means beautiful ignorance. And what it means is they're not really worried about it. You would think if you suddenly if you suddenly were blind, that you would be very upset about it. You wouldn't be upset about, hey, I can't take this nursing exam right now. You would be upset that you're going to be blind for the rest of your life and disabled and not be able to see. And so, that student displayed this also, that she wasn't it was like the being blind made her more relaxed, and that's a big hint that it's functional neurological symptom disorder and not something wrong with her eyes or her brain. And so la belle indifference is an important concept to carry forward into your career, because you might see a patient where you're trying to figure out why can't they walk, and then they're not you notice they're not worried about it, and you remember good old Professor Wheeler told you that about this disorder, that it's probably this condition. And in that case, what you would do is try to help the patient with what they're concerned about. What are they anxious about? And when their anxiety resolves, they'll be able to walk again. All right, so our friend Dr. Freud here. So in the psychodynamic theory, they saw conversion disorder, functional neurological symptom disorder, we call it now. It represents emotions associated with a traumatic event that are too unacceptable to express or are acceptably converted into physical symptoms. So it's like your psyche can't really handle the stress, and so it makes it a physical symptom that actually protects you from the stress. Our next disorder, factitious disorder, this is the conscious, intentional feigning or faking of physical or psychological symptoms. And so the person in this situation, they pretend to be ill in order to receive the emotional and support that you get when you're in the role of the patient. So this is a person that well, let me rephrase. One thing you'll notice in your career is that what we pay attention to as a nurse, when we give our attention to patients, and we'll talk in a minute to patients, caregivers, for some people that is very rewarding. You don't realize it, but you can be a very important person in their life just by being being a medical professional. And so anyway, there's people where this is it's so rewarding to be in the role of the patient that they fake a disorder, just to be in the role of the patient. It's different. You'll see at the bottom here. There's something you may have heard of, especially if you work in healthcare, something called malingering, where the person actually is faking an illness to avoid consequences. I'll see this a lot on the psychiatric units where, I'm admitting a patient that was suicidal and then they're worried. It's like, oh no, I'm on a 5150. I have a court hearing tomorrow, and then that makes you suspicious that it's actually malingering, where they're faking an illness to avoid consequences. So the American Psychiatric Association said, actually when they really look at it, that faking an illness to avoid consequences is a rational thing to do. They don't recommend it, but they say it's a rational thing to do. So it's not really a psychiatric disorder. But we still talk about it because it is common to see in the field. So the difference between factitious disorder and malingering is that the person with factitious disorder, they're not trying to get out of something. They get a lot out of the being in the role of the patient and the attention from caregivers and mental health. I'm sorry, medical professionals. The person with malingering, they're just trying to get out of consequences, and so very different. They both fake their symptoms, but for very different reasons. All right, and this was just a cute little thing somebody posted on Facebook once that works in corrections. A common thing in malingering with people going to jail is they think if they say they're suicidal, they'll go to the psych unit instead of jail. And so correctional facilities, they can make you wear these I guess they're like foam outfits where there's nothing where you probably know from my suicide lecture, you can tie your clothes around your neck and tie it to something else and try to hang yourself even if you're not high. High, you don't have to be elevated off the floor to do that. You just need to lean forward. And so that, prisons and jails know that, so they can change people into these little outfits you see there. Those people, they don't look very happy wearing those outfits. All right, so continuing, factitious disorder used to be called Munchausen syndrome. Um, there's also another condition called factitious disorder by proxy. They now call it factitious disorder imposed on another person. And what that means is you enjoy the attention that you get when you're the parent of a sick child. And this has been one of the very serious, very upsetting type of disorders that people can have. And like you see on my slide, famous for mothers intentionally making their children sick because they enjoy the attention from healthcare professionals. So this, you've probably seen it on, different TV shows or movies where this happens. One famous example, there's the rap singer Eminem in his song "Cleaning Out My Closet," where he's talking about breaking off his relationship with his mother. He mentions that he was a victim of this, that his mother made him sick on purpose because she had this condition. And Child Protective Services, they're very aware of this. And what happens when we have these type of situations is the law enforcement gets a warrant to take all the electronics out of the house And what they'll usually find when they go into the electronics is they'll see the mother was looking up basically how to poison their children safely, how to make them have symptoms, but not actually kill them. And so, you know, that's one of the more disturbing conditions that we have for most people. All right, our first question here, a patient experiencing lower extremity paralysis is admitted to a medical unit. Extensive tests confirm disability, but rule out any underlying organic pathology. What they mean by that is the person really can't walk, but they can't find a reason why. The nurse concludes that this is most subjective of which disorder. If you want to think about it for a second, pause the recording right now. All right, the answer is A, conversion disorder, although remember that's actually called functional neurological symptom disorder now. I think I like conversion disorder better. It's more descriptive because it's like the psychological concern is converted into a physical concern that's usually more acceptable to the person. So our desired outcomes for all of these conditions is that the person will cope effectively without needing to resort to physical symptoms. They'll have relief from their pain if pain is one of their conditions. They'll have less physical complaints and they'll interpret their bodily sensations rationally. And that last one is with a focus on illness anxiety disorder, where they interpret their body sensations irrationally and in an exaggerated way. And then the last one is they're free of physical disability, so they're able to walk, they're able to do everything they need to do in their life. Our second question, when working with a patient diagnosed with somatic symptom disorder, which is the most appropriate nursing action? A, avoid discussing social and personal problems. B, focus on the physical symptoms. C, always meet the patient's dependency needs. D, initially focus on the physical symptoms and gradually attempt to get the patient to discuss psychological concerns. Again, pause the recording right now if you want to think about it for a minute. Okay, so the answer is D. You want to initially focus on the physical symptoms to build rapport with the patient. Remember, if you've ever had someone in your life tell you that it's all in your head, it really invalidates your experience and makes you not want to talk any longer with that person. So we want to validate their physical concerns. Do your normal head to toe, whatever physical tests you would do, whatever labs or things that would be ordered. But then you want to try to get the patient to discuss their psychological concerns. What are your stressors? What's going on in your life? And hopefully that once you get into the psychological concerns and give them some relief there, if you've learned our therapeutic communication and you're good at it, you should be able to help them with their psychological concerns, and then the physical symptoms should go away. Looking at our objectives, just to review, number one, discuss historical aspects and epidemiological statistics related to somatic symptom and related disorders. So historical aspects, these disorders have been thought to occur in response to repressed severe anxiety. Epidemiological statistics, remember the prevalence is about 5 to 7% of the general population, but remember that goes up to 17% of the actual patients that we see in primary care settings that present for problems, which makes sense. And then there's a higher, it's much more common among females on a 10-to-1 ratio. And patients that have certain disorders, functional disorders like fibromyalgia, irritable bowel syndrome, chronic fatigue syndrome, they're more likely to have this type of diagnosis. And then also certain personality disorders where they have avoidant, paranoid, and obsessive compulsive personality disorders. Okay, so looking at objective number 2, describe somatic symptom disorder. Objective 2 has several parts, so we'll spend a minute on this one. So somatic symptom disorder diagnostic criteria: one or more somatic symptoms that are distressing or result in significant disruption of daily life. And then the second part, excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns. They are manifested by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, or excessive time and energy devoted to these symptoms or health concerns. And then there's C, the last part of it. Although one somatic symptom may not be continuously present, the state of being systematic is persistent and usually more than 6 months. And so they don't have to have the same symptom for the 6 months. They just have to have a serious somatic symptom for 6 months. Okay, so looking at illness anxiety disorder. So the big thing with illness anxiety disorder, they don't have symptoms that are not really there, not shown by organic pathology. What they have is they misinterpret their own normal body sensations and exaggerate them and believe that they have a serious disease based on an accurate, they might have symptoms. I think I gave the example of if you go for a long hike and you're not used to that and you have a little soreness in your calf, the person with illness anxiety disorder might interpret that soreness in their calf as maybe a blood clot that's going to break off and go to their brain and give them a stroke and kill them, or seriously disable them. And so they're panicked about something that most of us would just say, oh, my calf's a little sore because I did a hike yesterday. And then we have functional neurological symptom disorder, used to be called conversion disorder, and that's where the person loses a function of something where it's like they can't lift their arm, or they can't walk, or they can't see. I gave the example of my student that suddenly could not see during an exam, and the well, I'll talk about the bowel indifference on the next slide. And then we have our factitious disorder, where there's a patient that loves being in the role of the patient so much and loves attention from medical professionals so much that they fake a serious disorder. They consciously fake a serious disorder to get attention from medical professionals. All right, and then we have number 3, predisposing factors in the development of somatic symptom disorders. So generally these are people that are kind of dependent. They're usually, I don't know if I have it on a slide, but they're usually kind of undereducated, and and tend to see the world as kind of happening to them instead of them having an active free role in the world. Objective 4, describe appropriate nursing interventions for behaviors associated with SSD and related disorders. The big one I want you to remember is when you have a patient that you think might have this condition, before you try to get into their psychiatric concerns, you really have to take their physical concerns seriously. And so to in your orientation phase of your development with your relationship with the patient, you have to develop rapport, and you have to develop rapport by taking their physical concerns seriously. Once they feel like you take their physical concerns seriously, then they can be open to talking about their psychological concerns. But they're not going to be open to them if you don't take their physical symptoms seriously first. And like I said earlier, if you ever had somebody tell you your symptoms were all in your head, you know how invalidating and how insulting that feels like. Number 5, what is factitious disorder by proxy? That's the disorder where a parent, it's usually a parent, but it could be just a healthcare, a caregiver, actually makes the person they're taking care of sick on purpose because they enjoy the role, all the attention of from healthcare providers, and just regular personnel, they enjoy that attention, and so they actually make their person they're in charge of taking care of sick. And so it's a really emotional thing when you have a case like that. It used to be called Munchausen's by proxy, and actually they changed the name to factitious disorder imposed on another, but you might see it called factitious disorder by proxy. They just always try to make things a little more clear, but that either one of those would work. Anyway, it's very upsetting when you have a situation like that. It's usually the mother of a small child that we discover these cases. And in our culture, well, probably in every culture, we trust that our mother is somebody that takes care of us and cares about us and would never intentionally make us sick. And so it's very upsetting when we see a situation where the mother is making a child sick. All right, number 6, how is factitious disorder similar to malingering, and how is it different? And so factitious disorder is similar to the concept of malingering in that it is faking symptoms, but it's different in the way, in the goal of the faking of the symptoms. So factitious disorder, the person just wants to be in the role of the patient, wants to be taken care of, wants attention from medical professionals. And in the situation where somebody's malingering, that's somebody faking symptoms to avoid some kind of consequences. Then number 7, define labile indifference and how it can help identify if the patient has functional neurological symptom disorder, conversion disorder, instead of a serious physical condition. So this is a very simple one. If you see the patient has this loss of the use of a limb, the person finals week is coming up and they can't move their arm, so how are they going to write their paper? Something like that. And what you notice about them, if they actually have functional neurological disorder and not really something physically wrong with their arm, is that they're not worried about it. In fact, it actually relieves their stress because it gets them out of what they were anxious about, which was writing their term paper. All right, so that is it for our short lecture of somatic symptom disorders and related disorders. Thank you for sticking with me to the end here.